and to make it interactive as much as possible. Everybody here has some experience, so let us all exchange information.
Shall I start? Good afternoon, everyone. Thanks for the Bombay Orthopaedic Society for inviting me here. Today I am going to talk about use of the posterior portals in the knee arthroscopy. The learning objectives of these lectures are indications for the posterior portals, anatomy of the posterior portals, tips and tricks to create the safe portals, and learn about the complications of the posterior portals. The indications for the posterior portals in orthopedics, these are PCL avulsion fracture and PCL reconstruction, posterior horn of meniscus repair, ramp lesion especially, posterior compartment synovectomy, loose bodies in the posterior compartment, popliteal cyst, ganglion cysts and tumors, and arthroscopic, nowadays that is coming up, that is arthroscopic popliteus and posterolateral corner reconstructions. Everybody should have the posterior portals in his armamentarium for arthroscopy, because these are some difficult challenges are there in the posterior portals. One is, there is a very limited space, especially posteromedial portal is having a bigger space than the posterolateral portal, and there are many vital structures in the vicinity of the structures in the portals. The asterisks are showing the posterior portals. The saphenous nerve and the vein, they pass just nearby the sartorius, and you have to do take these portals always in a flex position, so that these all important structures falls away. And it has been statistically proven that these structures fall away in 90 degrees of flexion. The posteromedial portal you create just behind the MCL and anterior to the sartorius always, because saphenous nerve hardly come anterior to the sartorius, and you have to go bang in that area. You have to mark the portal preoperatively, as you can see in this screen, and you put the scope in a diagonally opposite portal, that is an anterolateral portal, and so that you can get the illumination in the area of the soft spot, that is a posteromedial portal. That's how you achieve the portal with a needle, then dilate it, and then you can pass a cannula. Posterolateral portal, common peroneal nerve along with the long head of biceps is immediately posterior to that. So whenever you are having a high suspicion of posterior horn of medial meniscus, lateral meniscus tear, you have to take this portal, because there is a septum in between, and that tear you cannot visualize from the posteromedial portal. So posterolateral portal is taken like this, anterior to the biceps tendon. Then here you can see there is a marking of the fibular head which is done, and there is a spot which is marked. And similarly you can pass the scope in the anteromedial portal, so diagonally opposite you can get the soft spot highlighted by illumination, and then you can take the portal. Dual posteromedial portal is designed because in conventional technique viewing portal was on contralateral side. That is, from posteromedial side you are viewing, and working from the lateral side, that becomes difficult, triangulation was difficult in the limited space. And again septum you have to cross. That's why two posteromedial portals, they are designed so that easier triangulation and easier instrumentation in a relatively bigger posteromedial compartment. So potential applications of dual posteromedial portal are identification and removal of masses, arthroscopic synovectomy, loose body removal, use of accessory portals during PCL reconstruction, meniscal root repair and posterior horn repair, and ramp lesion repairs. Now here you can see the needles, they are passed in two ways. You mark the soft spot by transillumination technique, then draw a line from the posterior part of the posterior cortex of the femur, and that should go in the center of that soft spot. One portal has to be taken proximal and posterior, and other portal distal and anterior. Here you can see the placement of the two needles, so that you can do a better triangulation. Here in this schematic diagram it has been shown like that. So advantages and disadvantages of dual posteromedial portal. Advantage is improved access, instrumentation, easier triangulation, indirect visualization. And direct visualization is possible and better to work. Disadvantages, obviously lesser familiar technique. Then transseptal portal is also designed. The posterior septum is an inverted triangular septum, and it is consists of two layers synovial reflection. It divides the posterior compartment into posteromedial and posterolateral compartments. Here you can see the septum in the MRI, and you can note the medial side the space is more, it is 1.5 times more than the posterolateral side. The transseptal portal is used in visualization of the posterior superior aspect of the femoral condyles, posterior portion of the PCL. The transseptal portal uses total arthroscopic synovectomy, removal of loose body, suture fixation of the PCL, all inside repair of the meniscus, and PCL reconstruction. While taking this transportal septal, you have to transseptal portal, you have to put the blunt trocar first, then identify the septum. Then Dr. Ohishi here described a K-wire needle technique, K-wire positioning technique, because what he says, if you put a blunt obturator, that obturator is trained to slide posteriorly and always pass the instrument from the lateral side, because the popliteal artery lies just 10 mm posterior to that on lateral side. So better to put the instrument from the lateral side, and the trocar tends to slide posteriorly as it is a blunt. So put a K-wire and see in the sheath only, and view it from the opposite side, and then dilate it serially. And it has to be taken in the distal part, not the proximal part, because vessels, medial genicular vessels, they will cross in the proximal part. These are some uses of the posterior portals: PCL, avulsion, fixation, suture bridge technique. Next speaker is going to speak about that. Ramp lesion repairs, posterior compartment synovectomy, as you can see here. Synovectomy using transseptal portal, then loose body excision, arthroscopic PLC reconstruction. I haven't got any experience in that, but I have copied these images from the net. I will tell you clearly. And arthroscopic Baker cyst excision. You can inject the methylene blue dye in the cyst, and where it leaks, Dr. Bancha has shown it in the previous case, I think so. That is a very nice technique. I have done 2 or 3 cases. Take home message is posterior portals are essential inclusions in arthroscopy, knee arthroscopy. Better understanding of pathoanatomy is better. Then properly executed steps will end up with a safe posterior passage. Expanding the horizons of the knee arthroscopy is possible with the apt techniques of the posterior portals, and recreation of the anatomy is much nearer the normal. Last but not the least, if you respect the tissue, tissue will respect you. These are a few references. Thank you. All are having more experience than me regarding
At the end, question at the end. End, better, no?
Okay, I'm Sajeer. I work at Sportsmet, and primarily I work in the knee and the shoulder arthroscopy division. And this presentation essentially is sharing my work with the central quadriceps tendon use in our scenario. And as an overview, I would like to share the graft that we harvest, what are the dimensions that we get, how to harvest it, and what are the fixation options that we use currently, and some of the issues that we have faced in our scenario. So this is not a new graft. This has been described in as early as 1998 by Fulkerson and colleagues. He had done extensive research and shown how to harvest, how to apply in an ACL. So it's almost a 40-year-old graft, but we have been using in our setup since almost 4 to 5 years only, probably because of the fixation technique, the graft harvest techniques. It was just refining. And we started applying it in our revision scenarios, and later on we have now extended it to primary cases where we find the hamstring may be inadequate, like in an obese individual or a hyperlax individual or an individual where we are expecting the hamstring to be inadequate. So basically we are taking the central soft tissue only portion of the quadriceps insertion. So this is the portion that we are talking about, and essentially the soft tissue portion only will come up to around 8 millimeters, 84 millimeters, that is around 8 centimeters. 7 to 8 centimeters is what we usually get. And studies have proven that it has contents of more than 20% collagen, 30% more fibroblast when compared to a bone patellar tendon bone, and the load to failure ratio of when compared to a similar size bone patellar tendon bone is 1.8 times better. But clinically it looks like this graft is a very viable, strong, thicker graft when we apply it in our setup. We move the portion of this slip that we take slightly 5 mm lateral to the midpoint of the patella, we can obtain the maximum length of the graft, and this has been proved in cadaveric analysis. And essentially there are 2 layers that you go through, and the superficial layer is the layer of the rectus femoris insertion, and the deep layer is the vastus intermedius, and a combination of both of these together forms up to double the size of a bone patellar tendon bone. So you can opt for taking only the superficial slip of the soft tissue central quadriceps tendon by using a small incision such as this, and get a decent enough graft of around 8 millimeter, 9 millimeter for applying in a primary ACL reconstruction scenario. With a minimally invasive technique and instruments such as the double blade plate and the cutters, you can give small scars. But the issue in our setup, we tried these and found that the apex, like I told, is slightly lateral, and one may end up cutting the graft into the muscle belly rather than the tendon. And we may get inadequate, insufficient length grafts and also end up injuring the muscle tendon. To differentiate between the superficial and deep layer, there's always this a layer of fat which comes in between, and so one can decide where to stop when you're taking a full thickness or a partial thickness central quadriceps tendon graft. Our preferred technique is the open technique now. We take the slip by visualizing the entire length of the quadriceps tendon, take the superficial or deep slip based on the amount of collagen that you're looking at, and detach the graft without injuring the muscle belly, and that way you have a very safe harvest of the central quadriceps tendon. The ideal method of fixation that we used to do initially by just whip stitching and passing a screw, but the problem with screw insertion is it tends to injure the graft during the passage of the screw, and hence we have now transitioned to use of adjustable buttons. And while using adjustable buttons, you use adjustable buttons and use high tensile tape suture materials to pass loops between the adjustable button and the graft to create a closed construct such as this. Here we are using this implant called the fiber tag, which has a tape at one end and a suture which is put on a straight needle. And you, by passing sutures between the adjustable button and the graft, serially whip stitching one end, we can get a closed construct, and we don't need to insert a screw. We just pass the button, flip the button, and shorten the loop to have a secure femoral fixation for the CQT graft. Here we have used a partial thickness because we didn't want a full thickness, because we do a remnant preserving ACL most often. Some of the concerns which pushed the central cord tendon away was the scar, was the inadequate graft, is the weakness of the extensor mechanism, and some of these issues that we have seen in our setup is such bulge which has come up in a basketballer almost 5 months post CQT ACL. You can see the scar of the CQT below. This is actually a rupture of the rectus femoris, or the detachment of the rectus femoris, because your strip extended into the rectus femoris muscle belly. So this can be avoided by clearly visualizing the proximal apex of the tendon in an open technique or in a mini-invasive technique. You can put a scope in and visualize the apex of the tendon and mark this area so that you are sure where you are passing your stripper into. And such defects which are left behind, especially in a mini-open technique, is quite cosmetic and troublesome to the patient. So this can be avoided by, really two-layer closure, very easy in an open technique. But if you're looking at an arthroscopic technique, it's quite tedious, long, but still doable and possible. Yeah. So these are some other techniques that has been described in literature, but just to sum up in conclusion, this is the bone patellar tendon bone plug with quadriceps tendon. The issue with this is the patellar fractures which we come across. So in summary, this central quadriceps tendon option is a better collagen. It is a reliable graft. It has versatile options, and improved harvest techniques and fixation has made it our primary choice in many cases. Thank you.
Very good. I think showing complications is very informative. Thank you.
Keynote. Hello everyone, I am Dr. Fayaz Memon from Mumbai, and I will be speaking upon arthroscopic PCL tibial avulsion fracture fixation with suture bridge technique. I am sure most of you people know about it. The classification of PCL avulsion injuries is type 1, type 2 and type 3, as we all know. Diagnosis apart from clinical is done by X-ray, MRI, CT scan if required. Management can be conservative if it is undisplaced and where the displacement is more than 5 millimeters, or the posterior tibial translation on posterior draw test is more than 10 millimeters, then we opt for fixation. We know it is open and arthroscopic, and I'll be trying to enlighten about the suture bridge technique for arthroscopic PCL avulsion fracture fixation. So what basically we do in a nutshell is pass the loop of the suture around the PCL, tie the knot there, reverse the knot, and then pass the two limbs of the suture through the tibial tunnel infero-medially and infero-laterally to the tibial trough, and then pull it and tie it. This is all, as simple as that. Do not forget to do examination under anesthesia. This is the position of the limb that I prefer, keeping extra space on the medial aspect of the knee. I usually prefer, after long experience of these cases, keeping 2 monitors, one on either side, because otherwise it becomes difficult to keep your neck on one side. Standard anteromedial and anterolateral portals are used. High posteromedial portal is used, and I use an extra low posteromedial portal for instrumentation. So it is very easy from behind while you are seeing from the superior portal and operating from the inferior portal. This is that extra portal. Once you find intraoperatively that the sloppy ACL sign is positive, the first thing that you do is clean the intercruciate window. You create this window by cleaning the synovial tissue in between the PCL and the ACL. Be careful, do not go too much posteriorly because you do not have too much space between the neurovascular bundle. Keep your instruments at the level of the posterior margin of the PCL and create this intercruciate window. Pass your scope through the intercruciate window and visualize the posteromedial capsule. Once you visualize the posteromedial capsule, make 2 posteromedial portals, one superior and one inferior. The inferior one is utilized for instrumentation where we put the 8.5 millimeter cannula, and the superior one we use our regular inflow cannula for visualization. Remember, superior is for eyes. Once done, shift your scope to the superior posteromedial portal and use this elevator from the anterior aspect behind the PCL to create space between the posterior structures and the PCL. Once you separate with this blunt elevator, you safeguard your neurovascular structure, and once you do this, you are there at the fracture site. You can observe that there is a tibial trough and the bony avulsed fragment. Having done this, clear the debris in the fracture site by using your shaver and the suction, and then pass the pilot thread using your elevator again, which has got a hole into it. Loop it around the PCL and take out those 2 limbs of the suture from the anteromedial surface. And then visualize this from the anterolateral portal. Make the loop around the PCL with this fiber tape. Earlier we used to use the suture, now we use the fiber tape because it is thicker and better. I use 2 half hitches for the knot. Remember that the knot should neither be too tight nor too loose. Then flip the knot on the posterior aspect and keep the 2 limbs of the fiber tape in the posteromedial aspect, thereby reversing the loop. Now again shift your scope to the posteromedial portal, the superior one, and retrieve the 2 limbs of the fiber tape from the inferior posteromedial portal and keep the knot bang behind the PCL. Use this PCL tibial guide for creating 2 tunnels, one infero-medially and the other infero-laterally. First create the infero-lateral one. Remember that the length of the pin should be adjusted precisely to avoid any inadvertent injury to the posterior neurovascular structures. You can use the fluoroscopy if required. Usually you don't need it. Once you have passed the inferior posterolateral tunnel, pass the nitinol loop and railroad one of the suture limbs through it. So your one suture limb is secured through the posterolateral tunnel, and then repeat the same step for the inferior posteromedial tunnel through the tibia. The other limb is now passed through the medial part, the medial tunnel. Once you have pulled the sutures through the tunnel, pull these sutures anteriorly, and once you pull, the fragment gets reduced. However, you need to see that the fragment has reduced. And once you confirm that it is reduced without doubt, you can tie the knot. This is how it looks post-operatively. This is the pre-op and the post-op X-ray, and this is the stability at 6 weeks with good range of movement. The complications include, as we all know, neurovascular structure injury, compartment syndrome, arthrofibrosis, and so on and so forth. We start rehabilitation immediately, active hamstring after 3 weeks, full weight bearing at 6 weeks, running under supervision for 3 months, after 3 months, and return to sports at 6 to 9 months depending upon strength. I thank you very much for your kind attention.
Sir, वहाँ पे.
Dr. Ankit Marfatia is going to talk about remnant preservation and footprint restoration. Dr. Ankit.
Yes, sir. Thank you. Yeah, hi. I'm Dr. Ankit Marfatia, Assistant Professor from Grant Government Medical College and JJ Group of Hospitals. So we do a diagnostic scopy, and this is the picture that comes. ACL that is completely torn and the remnant is there. What should we do next? Remove the stump, preserve the stump. That's the question. So earlier I used to debride everything because I didn't need to know the normal anatomy. I used to use a shaver. If access to a burr, I would use a burr. Even use a RF ablator to clear up the footprint completely. But then I read the literature. And the literature stated that Butt et al. Have come up with a paper in 2020 which stated that the microvascular structures are present during the first year after an ACL injury. And after the first year, if the injured ACL stump is present, then it becomes avascular. So it was time specific that the vasculature was present. Gao et al. Have had a presentation on there are Golgi-like tendon apparatus present, nerve endings present on an ACL stump. So there are chances of proprioception which can be possible in an ACL stump. So that made me wonder what are the different types of stumps that are available. So Crane et al. Have described that. They had 4 groups which are present after a ACL injury. Group 1 was where the scarring tissue of the ACL stuck to the PCL, which is seen in the picture next to the diagram. Group 2 is the scar tissue is on the roof of the ACL, which is there similar to how it was in our first case. Type 3, group 3, is where it is malunited or it's fibrosed to a different part of the lateral, to the lateral medial aspect of the lateral femoral condyle. And type 4 is what you see when you see a chronic injury, which is just a remnant resorbed ACL stump. So then I went through the literature, and literature has got multiple reviews, and they all stated that the lysosomal scores of the patients would improve and the side to side would improve. However, there was no current consensus on the same. When I went through this paper, it stated that Louis et al., when they went for a relook surgery, there was better synovialization of the ACL graft in remnant preservation as compared to remnant removal. So that was something that was of importance for me. They also said that there was a higher expression of ligament healing in this paper if it was done within the first 3 months of injury, because the vascularization which was shown in the histology was better as compared to a chronic injury. In this paper it is 3 months. In the previous histology paper it was 1 year. So what do? The complete remnant ACL is present. The remnant is preserved. The femoral attachment of the ACL is just debrided, but the ACL fibers are still visualized in the femur. The tibial end is preserved the stump shows vascularity. That's a very important thing for synovalization of the ACL that is going to be put in next. The femoral entry can be made at the part where the stump is on the left, and using an elbow jig, the tibial stump can be protected. The video on the left is a very interesting video. That is how you preserve the ACL stump. The drilling is done by a trained hand who understands the feeling of give way, and so as to not injure the ACL. There's a dance that happens around the ACL stump prior to the give way, and that is very important. This is a reconstructed ACL with the remnant preserved. You also have to check whether extension is possible. Because of so much graft present inside, there can be some extension problem. So what is the way forward? Again, while coming across, there's a paper by an Indian author in arthroscopy technique, which says of taking sutures through the remnant stump and then passing it across and tying it onto the endo button. Now that is something that I do not do, and therefore that is something that the way forward for me personally. What are the complications of remnant preservation? A cyclops lesion. This will cause difficulty in extension. It has to be dealt with. The patient will not be able to walk. However, if you notice on the left side, there is complete synovalization of the ACL graft at 4 months. So that's a good point, but there can be lesions like this. So we have to be worried and be aware of such things. So the conclusion point is, preservation of remnant leads to better synovalization. Remnant preservation leads to better proprioception, but these are histological evidences. There's no concrete evidence on the same. Preserving the femoral fibers will assist in placing the appropriate tunnel. Tibial end drilling must be done carefully to preserve the remnant. Thank you so much.
Yeah, Dr. Nikhil Agarwal.
Yeah.
He's going to talk about augmentation techniques in ACL reconstruction.
Very good afternoon, friends. So what do you mean by augmentation? Augmentation means provide additional strength and support or aid faster healing and maturity to your intra-articular ACL reconstruction. Hello, I'm Dr. Nikhil Agarwal from Mumbai. And we all know that arthroscopic ACL reconstruction, despite the best of the techniques, there is 0.7 to 20% chances that the patients do land up with recurrent instability, especially the rotational instability. There is a risk of graft failure and overall revision rates of 8.4%. So the aim of all the ACL reconstruction is to restore both AP and the rotational knee stability and early return to activity and function. But despite the modern arthroscopy techniques, the return to high-level sport and return to function and activity of many of our patients is unacceptably low. This residual rotational instability is a major concern and cause for the recurrent injuries post-reconstruction. And this instability may not be fully restored by our standard intra-articular reconstruction. So establishing the rotational stability is very important, and it correlates with return to sport, a high functional score, and overall knee function and patient satisfaction is very important if we restore the rotational stability. And a lot of techniques have been involved. We started with the transtibial single bundle technique, then over to the transportal anatomical single bundle technique. Even the double bundle ACL reconstruction techniques were described in between, but it didn't succeed to achieve the rotational stability. And now something extra has been added to this anatomic ACL reconstruction. And there are certain high risk of patients, a subset of patients which are more prone for higher re-rupture and the re-revision. And these are the patients with a severe grade 3 pivot test, a young population involved in pivoting sports, hyperlax, ligament lax patients, recovertum, and patients with high tibial slope. So this is a clear grade 3 pivot with a severe rotational instability along with the anterior posterior instability. And there's something has to be added to this procedure, to these patients in addition to your ACL reconstruction. We all have been concentrating only on the central pivot, that is the ACL reconstruction to establish stability, and forgetting about the anterolateral structures which are generally and more commonly injured along with your ACL tears. Hyperlax and knee hyperextension do also predict post-operative stability and function of your ACL reconstruction. And in these patients, we have to do something extra to your anatomic ACL reconstruction. Posterior slope of more than 12 degrees have been associated with ACL graft failure, and we need to address this, also see this in the preoperative time. You try to measure the posterior tibial slope, and more than 12 degree you have to add or augment your ACL reconstruction with some other technique. So unfortunately, high rates of graft failure and persistent rotatory laxity has been observed, particularly in these high young demand individuals and returning to contact previous sport, and we need this augmentation. There are different methods how we can augment your arthroscopy ACL reconstruction, extra-articular methods, some internal methods, and certain biological methods which will address the graft healing and the graft maturation. The mechanical methods are broadly the lateral extra-articular procedures which are commonly done is the anterolateral ligament reconstruction. Lateral extra-articular tenodesis procedure, most common is the modified Lemaire procedure along with your arthroscopy ACL. Suture tape augmentation is the internal augmentation, and certain biological augment methods are with PRP and fibrin clots. We will understand one by one. Amongst the lateral extra-articular procedures, which are the most commonly performed procedure, are the anatomic ALL reconstruction and lateral extra-articular tenodesis, commonly known as LET, where we use the IT band in different fashion, in different ways to address the anterolateral corner deficiency. So addressing the ALC, that is the anterolateral corner, reduces the anterolateral rotation. It decreases the strain on the ACL graft, decreases the prevalence of pivot shift, and thereby reduces the rate of ACL graft failure. So the anterolateral ligament is triangular complex, and some of the authors do believe it's a single ligament on the anterolateral aspect of the knee. Many times you see a Sigon's fracture, but most of the times you may not get this classical sign of anterolateral ligament tear. This is the ALL reconstruction. It can be done as a single bundle or as a dual bundle also, where the graft, a free graft is passed from the femur and the knee just posterior and proximal to the LCL tendon. Lateral, the extra-articular tenodesis procedures have been done in the past. It has been described in 1967 by Lemaire, 1972 and 79 by different authors, where the split IT band is used to augment the lateral side. Commonly we do is the LET procedure, where the IT band is split, passed beneath the lateral collateral and attached proximal and posterior to the lateral epicondyle. So this is a grade 3 pivot which we started before doing any surgery. After that is the grade 1. After doing the ACL reconstruction, there is some pivot still left. So we plan to do the our modified Lemaire's technique, and the incision is on the lateral side from the femur epicondyle to the Gerdy's tubercle. We expose the IT band and mark the posterior aspect of the IT band and split it from the proximal end, keeping the Gerdy's attachment at the Gerdy tubercle intact. We identify the LCL and pass the split IT band beneath the LCL and then attach it with a screw on the lateral side. You can also use a staple or an anchor. So the clinical outcomes of these contemporary lateral augmentation techniques in ACL reconstruction in a systematic review have shown a very good rotational control and a significant decrease in the graft failure rupture of your ACL reconstruction. However, the clinical outcomes, the lysome score is supposed to be good, but the IKDC scores may not be as same as the intra-articular ACL reconstruction. Markachi and et al. Have described a technique where they use the hamstring graft for the ACL reconstruction, keeping the insertion intact, and the same graft they have passed on the lateral side as an extra-articular tenodesis procedure. And the combined ACLR and LET have shown a very positive effect even on the graft healing and the graft maturation, because they have provided you a mechanical extra strength to the ACL reconstruction. So the ACL reconstruction healing and the maturation also has become better. So the literature supports addition of your addition of the lateral augmentation procedure to your ACL reconstruction. And of course, we have to take care of the meniscal root, the ramp lesions, and the corner injuries, which, because if any of these have been not addressed, it will lead to a residual instability. Some points about the suture tape. The suture tape augmentation has been quite popular in the recently, and it has the authors who support this suture tape augmentation believe that it is supposed to protect your ACL graft in the early healing phase of the graft. And they are supposed to provide a biomechanical support. But is there the real benefit of adding this graft is still very doubtful. It's still experimental, and it will not be recommended to add any fiber tape or an artificial tape in your ACL reconstruction. However, if your graft is thinner, less than 8 mm, I have personally used adding a internal brace. Last few seconds about biological augmentation. We all know the healing of the ACL graft is very important, and graft healing and graft maturation is very important for early ligamentation of your ACL graft. Fibrin clot have been identified and have been used to augment your biological augmentation of your ACL graft. The PRP also have been tried, and all these things are now to be a part of your, maybe for the future generation to augment your ACL reconstructions for better healing. Lastly, just I would like to give a summarize from the International ALC Consensus Group meeting. Consider adding your LET in certain subset of patients, definitely for revision ACLR, patients with high-grade rotational laxity, that is a grade 3 pivot, or patient with generalized ligament laxity, or a very young patient involved in pivoting sport. Thank you.
I think we have come
Dr. Nikhil, do you have any experience
Questions?
of doing this stenodesis percutaneously? And if you say yes, then do you have any experience of any problem in this technique? Any issues?
Percutaneously, we can do the ALL reconstruction, but the tenodesis is an open technique. However, you can reduce the size of the incision, small, maybe a 5 centimeter incision, but it's an open technique.
Have you done this?
Yeah, we are the case which I've shown is mine, but as you asked, the problem with this technique might be when you're putting your, if you're using a screw on the femur side for the LET, it can coalesce with your ACL tunnel. So better you can use a staple or a anchor.
Okay, thank you.
Any other questions? We have time.
My question to Dr. Nikhil, regarding the biological augment, continuously irrigation is going on. Do you still feel that augment will remain there?
The biological, the fibrin clot, they have been shown, but they don't have any benefit as the literature says. But yes, it's a thing of the future, how to add to the biology of the ACL graft. I have not used personally any fibrin clot, but in literature they have shown they do not help much. But only in the animal studies, Freddy Fu's paper, I couldn't say in detail, they have shown that it helps in the early healing of the graft in the tunnel.
Good. If no more questions, we will finish earlier than time planned.
Just may I ask one question for the QC team?
Of course.
Yeah, it was a very interesting thing. Just wanted to ask whether the preoperative quadricep atrophy will help us in deciding or determining whether we should not use the QCT, because many of these patients are having quads atrophy. So still you will go ahead with it, or do you measure objectively anything, the quadricep strength, something like that?
No, frankly, we don't come across such a situation. We don't opt for a patient to go in for surgery with a quad atrophy. If at all, if there is a quad atrophy, and like you say, like bucket handle lock situation, where the patient's knee is too weak and the quad is too thin, the tendon integrity will be the same. So the quad muscle function has no relation to the amount or quantity of tendon that you're going to achieve. There has been articles which prove that doing a central cord tendon in the acute has extension deficit in their rehabilitation stage, but at the end of 1 year, their results are same.
Okay, thank you.
Dr. Usman, one more question I have for you. Using the CQT tendon, what is your case selection? I mean, when do you use a CQT versus a hamstring? I mean, do you have any particular class of a set of patients when you will definitely use CQT?
So as a part of second revision scenarios, we have fully transitioned to CQT. We have almost stopped doing bone patella tendon bones. And as a patient who is an obese or a hyperlax individual, or a patient even in high demand individual like top end footballers, We get a lot of hamstring injuries when we harvest the hamstring. I'm sure all of you have noted that when we get the hamstring out, the stripper doesn't pass well, and once we get it out, we see a lot of fibrosis and shredding of the hamstring fibers. So it has been proved that in footballers, these hamstring is not a option, and the better option would be a central quadriceps tendon. So our indications have broadened. We select most likely on table if we find a situation where Ankit showed that there is no remnant at all, and we want to fill the footprint fully, and we want a thick, big graft, we opt for the full thickness central quadriceps tendon. If we have a good remnant tissue, we still opt for the hamstring. If we have a hyperlax, obese, or a female whom we are not expecting a great hamstring, we primarily go for the central quadriceps tendon. And in those scenarios, if there is a good remnant, we take only the superficial slip of the CQT.
So another question about CQT is that if you have a medial side injury, ACL, medial meniscus, MCL, would you prefer a CQT or continue with the hamstring?
Yeah, so that's a standard theory where the medial side injury progresses by taking a hamstring in a medial sided injury. Additionally, the point is the hamstring
Dear
works against
colleagues and respected seniors,
someone else. Acha. Someone else wants to talk about it. So the other thing is the hamstring tendon works in pulling the tibia back. Actually, it is beneficial for an ACL deficient knee. By taking the hamstring out, it further increases the anterior translation. So not only medial laxity, it increases the anterior translation. CQT is better in both ways. So there are surgeons in France who have completely transitioned to only central quadriceps tendon. Dr. Pascal, he had come to our center for a demo of only mini-invasive surgery, but we didn't get great harvest through the mini-invasive technique. That is why we've shifted back to the open technique.
There's one more question there. Yeah.
Regarding the PCL reconstruction, I mean, it was talked about the